So let's talk about now COVID-19. We talked about how COVID-19 has been spreading around the countries and what's happening in these countries. Let's just look at the headlines over the weekend. Belgium announces return to national lockdown as figures suggest it has the highest COVID infection rate in Europe. Germany to enter 4-week lockdown from November. Chancellor Merkel confirms. UK Prime Minister Boris Johnson announces lockdown measures lasting a month in England. France returns to national lockdown and new surge in coronavirus cases. That is what is happening in especially the Western Hemisphere and Europe in particular. This is what's happening. Now, there is a term then that has come into operation. This is circuit breaking. So the kind of operation or meaning of the circuit breaker term is that gadget that is there, the switches in your house that in case there is a short circuit somewhere, in case there's a power surge somewhere in the line, then the circuit breaker goes off. You identify the problem, isolate the problem, sort out the problem, and then you switch it back on. This is helping you. Basically, it's like a fuse, or we can just look at it as the fuse in a plug. Many plugs come with a fuse. If there's a surge in current, or if there's a problem somewhere in the line, maybe with your gadget, there's a short circuit somewhere, the fuse goes off so that there is no power coming into the gadget. What you're basically trying to do is you stop electricity from continuing to flow until you sort out the problem and then you switch it back on. Sometimes the same thing that happens even when we have a blackout. There's an issue, maybe wires are stima zimeshikana, and then a fuse, the circuit breaker somewhere goes off, and it calls on the Kenya Power guys to come and see where is the problem, identify the problem, sort out the problem, switch that power back on. Sometimes you are saying, in some cases, where we have seen some serious proper lockdown, this is a case where the guys come and remove the transformer. There's no power. Transformer gone. So this is not circuit breaking. This is basically just saying no more power here for a while. So why is it the issue of a circuit breaker conversation coming into COVID-19? What does it mean?
What I think it's more of what it implies. It implies that there's a flow of electricity that perhaps in the quantity and the manner in which it's being supplied is actually not desired. So the only way you can halt it, the only way you can bring it to an end is with the circuit breaker. Now, the details of the circuit breaker perhaps are what we need to look into and to ask, okay, with the circuit breaker, what is it? Is it permanent? Is it periodical? What's the plan about it? And honestly, what do you expect to achieve? Because the initial lockdown was precisely that. At least that's what it represented, breaking that particular flow. Now, we keep talking about the new normal. And when you talk about the new normal, you're saying not that COVID will come to an abrupt end, but that we will have arrived at a lovely MOU with it where we can coexist with it without being a constant threat over our heads. So, does a circuit breaker represent all this, or what is it really, and how is it envisioned to be?
So every time you have a surge, circuit breaker goes off, then you identify the cause of the surge, you deal with it, and then you switch the power back on.
Yes.
And then you continue and until next time.
And I'm asking, is that really just it?
Is that it? And
Yes.
does it sort out our issues?
Yes, and if you look at, because now we are in November, so we've had months of COVID. Are there patterns that have emerged? Are there things that we probably previously didn't understand that we now understand, so we can actually bring these processes to a halt, not just mitigate against them for the time being, but ensure that they don't recur again, so that all we have to deal with are those processes and things or occurrences that we couldn't have foreseen. That's what we deal with.
Yeah.
But if we're dealing with things that we can foresee and things which we know how to mitigate against, then we aren't really making any progress, are we?
Let's bring in the experts, and to speak to us this morning is Dr. Githinji. Dr. Githinji is the Group Chief Executive Officer of Amref Health Africa, and Dr. Mercy Korir, Standard Group's editor in charge of health and science, joining us on the line. Doctors, good morning.
Good morning, Eric and City.
Good morning.
Good to have you both. And as we begin this conversation, I'd just like to recap what the latest figures that we have from the Ministry of Health announced yesterday. Total number of cases so far in the country, 55,877. Yesterday's cases, 685 confirmed in 24 hours from a sample size of 4,433, and 17 more people died between Saturday and yesterday. Now bringing our total death toll to 1,013. number of people admitted in hospitals, in various isolation facilities as well, 1,271. And those that have tested positive and are still positive but undergoing home-based care, 4,808. 53 patients are in ICU. These are high numbers. What do you make of them, Dr. Githinji?
Well, I think the first thing I would like to say is that the confirmed cases are laboratory confirmed cases. We know, of course, that there are many more infected people. We've seen studies in Kenya looking at people who may have antibodies or kind of size or footprints that have had exposure to the virus. And they are much higher than, of course, the 55,000. The 55,000 are the ones we've managed to test through tracing and tested and confirmed they're positive. Now, the most important thing therefore to look at is rather not the numbers, it's a trend. And the trend has actually been going up now since the first dip. We had a good dip post-August, September. And after that, we have now seen this going up. Two things, positivity rate is going up, and the number of hospitalizations are going up, and the number of deaths out of those confirmed are going up. Remember, even when you talk about deaths, you're only counting the ones that die in hospital. Any ones that die in the community are considered police cases. So they may not be even in this number because we've not started doing post-mortem COVID testing. So they are rising. So my thought is that the numbers are rising. We expect them to continue rising. They are rising more in the outer counties, actually faster rate than in Nairobi. And therefore, we just need to go back and ask ourselves, are the counties prepared for any surge that may require hospitalization or hospital care? And how do we actually go back to thinking about reducing the force of transmission? What measures can we take to reduce the force of transmission?
Dr. Masi, what do you make of the numbers and the cases so far?
Okay. So I think for me it is no surprise that we are seeing that there is an increase in the number of cases, because if you can trace it back, you'll see that these numbers are rising since when the government eased the restriction measures, when the curfew was being eased out, when the number of people who could go to gatherings was increased. So you see that the trend is gradually increasing from that. So for me, it is a no-brainer that we are seeing the kind of numbers that we are seeing. And so if we want to control the numbers, then we have to rethink what we need to do. And we have to now really rethink it more critically, because here we have a balance between saving lives and saving livelihoods. Because we know that the reason why all these measures were being eased was so as to allow people to start making a living, so that people can start going about their economic activities. But now we are seeing that there is a cost to life. So for me, it is about going back to where we are seeing the numbers starting to rise, seeing what did we do at that time, and what can we do differently from that time that, one, will save lives, and two, also save livelihoods. So it is not really just about the numbers that going up. We expect that, but what do we do about these numbers so that we can, stop a further increase?
Dr. Mercy, do I understand you to say that we could have predicted this surge?
Yeah, we could have, definitely, because remember, we've been saying all along that the virus does not move. It is people who move. So if we are gathering, if we are moving from one corner of Kenya to the other, and it is no brainer then that the numbers would increase. So one, it's looking about what can we do differently. And as Dr. Githinji says, there is that our counties prepared. Or what can we do to prepare our counties to be able to respond, one, to the number of people in home-based care, and two, those who will need hospitalization. So for me, it is just about going to the next step. What do we need to do next to save lives and to save livelihoods, not one at the expense of the other one?
But when we talk about what next to do and the next steps to take, is this not something we've been talking about right from the very beginning when COVID reached our shores? Is this not a discussion we've had? So are we having the same discussion, meaning we're not moving, we're exactly at the same spot we've been throughout?
Yeah.
See, to this conversation, we've had it since March, where in this situation room, we've always been a step ahead of the government in terms of our thinking. So I think, let's just have this conversation about what's next. And we hope that the government and the authorities will actually now move faster than what we saw during the first initial surge of COVID cases.
Dr. Mercy, there's what next, as in what we've seen being done. There's what we know needs to be done or ought to be done. And then there's what in reality can actually get done. Now, how do you merge the three?
I think for me, what can actually be done, some of the things are low-hanging fruit. Political rallies and gatherings, for example, are they necessary? No. Our religious gatherings, our events and things like that, can we reduce the number of people who are there? Can we move back to online? I mean, some of these things are very low-hanging fruits for me in terms of what we can do next, and they're practical. I mean, if millions of people are going to be exposed to COVID-19 because you're having a political gathering, which one is more important, this political agenda or the lives of people who you will need for this political agenda? So for me, some of the things that we need to do are very low-hanging fruits. The difficult ones now will be the technical things where we need a lot more resources and a lot more technical people on the ground. So those ones are the ones that now, if we could get rid of the low-hanging fruits, then it would be now easy to focus attention and resources on those technical things that will actually save lives.
Do you think we could legally criminalize deliberate infections, meaning people who deliberately cause infections and people who themselves cause infections, knowing full well that they are COVID positive? Do you think if we made it an offense punishable by law, we might get some results? Dr. Gitai, what do you think?
You know, we've had incidences where, people, especially you've seen in South Korea, we've seen here also, we saw this happen in, with one of the deputy governors from Coast Province, where the state attempted to actually criminalize infecting others knowingly. Yep. And that is obviously a route that anyone can follow. You can actually sue for that. You can put a civil case for that. So continuing to actually, talk to people to ensure they understand that when you actually go to a place and you know you're positive and you put other people at risk, and that actually being chargeable by law is important for people to understand. It happens in other areas of infectious diseases as well, where you knowingly expose somebody. That could be a criminal case. But I think the issue we really need to focus on is the fact that there will be no, I have had you, talk to Masay and ask about why we're not doing the right thing. The thing is that when you have a pandemic, it's very difficult to know what is the right thing at what time, because the virus is always ahead of you. So you take measures based on the information you have at that particular time. Now, the first partial, because Kenya never went to a lockdown, we never really went to a lockdown, but the first partial lockdown that we had, where some of the businesses were closed, people are still allowed to move, though there were some areas with cessation of movement, had a huge impact on us actually reducing the force of transmission. Remember, the end game in trying to manage a pandemic like this is not to end the virus. The only way to end the virus is to get a vaccine, so that you vaccinate everyone and then you create herd immunity and the disease dies off. And then you maintain the vaccination over years, because we've seen that with measles. That's what we do. But now, after you do that fast control and you see the cases coming down, you then open up. That's inevitable, because the aim of the partial lockdown is not to end the virus. It is for you to protect your health system. And therefore, when you think you're protected and prepared enough, you open up. And when you see another surge, you should not be ashamed to go back and say, okay, we now want to. It's not like you made a mistake to open. It is that now you close again and you do what you guys were discussing earlier, called a circuit breaker. Your circuit breaker is really to break the force of transmission, so that now you protect the health system, and and then after that you continue to reopen the economy. It is kind of stop, start. It's not something that you made a mistake by closing the first time. No, it's not.
When I listen to this conversation, I'm getting worried that government officials will want to jump onto the international bandwagon and the catchphrases of the time. Remember, there's a time when the catchphrases were protocols. We have the WHO protocols, and we've come up with our own protocols. We have international protocols that are in place, and we have come up with our own protocols. In fact, we've already published them and we are sharing them. Now it's going to be this one. But at the same time, the government not doing what it could do, what it has power to do, which is even if we were to go into now a circuit breaker, which is just some lockdown for a definite amount of time, what is it that should be happening in the background? I'd expect that what should be happening is what could have happened in the first place, which is looking at your capacity, your preparedness, looking at your healthcare workers, looking at the projected numbers, because the experts are coming up with models and projecting those numbers. So what is it that you would do to make sure that you can address those numbers? But Dr. Mercy, we talked about this in March, in April, in May, in June, and saying at this time, as the government is telling us to do this, we hope that it's in the background, it's also putting in measures in place. Looking at the situation now, where we have 1,271 patients admitted in hospital and 53 of them in ICU, and already the healthcare system is feeling the pressure. Was there enough preparation put in place?
I think preparation, from what I've seen, is a continuous process. It's a process where you improve from one step to the next, so that because what we knew in March, April is not what we know now. I've met healthcare workers who had met in March, April, and I can see that their confidence in managing COVID-19 is much better improved now compared to back then. So there's been some progress, I must say, in terms of preparedness of the healthcare workers themselves, in terms of their psyche and psychological well-being to manage the pandemic. They know what is expected of them. They have an understanding of it, and that we've seen that the virus has not been as bad as it has been in Europe. So we've seen that there's some progress. So that said, in terms of the personnel being prepared, we need some things, some infrastructural adjustments in our health systems in our health facilities in order to manage the pandemic. One is availability of oxygen, of medical oxygen for people who would need supplemental oxygen, because there are people who will just need to be on oxygen for a while, then they go home. And then there are those people who will be in critical care, who will need now more intensive care, more serious care in terms of even what the equipment and the facilities are and the personnel that are there. So when you look at all of this, for me, I look at it as these things have to be addressed at the same time. Not one, then you move to the next, because people are presenting in different stages of the disease. So for me, my focus would be where at the most critical point of our healthcare system, are we able to handle the number of people that might be in need of healthcare services at that time? And unfortunately, as we're seeing now, we are not yet there. The other day I was talking to one of my colleagues, a doctor actually, who had to move one of their relatives from Nairobi to Nakuru because they needed critical care. So that tells you that our system, either we are getting to a point where we are overwhelmed, or our facilities are not enough to handle those at the most critical care of COVID-19. So for me, it's for the government to actually look at that. And that's, I think, what Dr. Githinji is talking about. Preparing your health systems to be able to handle the cases, not that you are working on, getting rid of all the infections or all the COVID-19 cases, but you want to be in such a position that when people need care at the farthest end of that continuum, at the critical care stage, then you're able to offer that kind of care. And if you're not able to do that, then we will see that we will lose people to COVID-19, and we lose a lot more people to COVID-19.
Dr. Githinji, are we at that point where we can say we are able to deal with the cases that are coming at us on a daily basis?
No, we are not. We have seen the surge overwhelm capacity. Remember, maybe a very quick review here for our viewers and listeners. That number one is that infections in themselves are not the problem. So seeing 1,000 people getting infected a day, or 2,000, or we know they are more infected, is not really the problem. The problem is, out of these that are infected, how many will require the health system? Because many of the ones infected are asymptomatic. We've seen most of the people infected, 93% of them or up to 90% of them are asymptomatic. No symptoms, no fever, no cough, no difficulty in breathing. And therefore, the most important thing for knowing about these is to ensure that you can actually ask them to isolate so that you reduce their chance of infecting others. The ones that we really are worried about and that require the circuit breaker are the ones who require hospital care or health system, whether they need to go to the hospital for oxygen, ventilator, ICU. And we've seen Kenya has very few ICU beds. If we're talking about probably about 400 beds of ICU, remember these beds are total. They have to be shared by people who need ICU, who don't have COVID, and people who have COVID. Also remember that the COVID beds cannot be in the main ICU. So you're actually saying that the ICU beds available for COVID patients have to be removed from the main ICU beds so that you don't infect other patients. So that means that the beds then available for COVID, for ICU, are much fewer than the 400, unless you're saying that you're occupying all the beds for the country. So basically, we're saying that we still need to do more to increase capacity for taking care of COVID patients. We need to talk about oxygen, as Mercy has done. We need to talk about what we call pulse oximetry to measure the amount of oxygen in the patients all the way down to the dispensary and all the way down to the health center. I feel like the challenge we're having is we are focusing too much on the COVID hospitals instead of devolving and decentralizing capacity so that the people in health centers are also able to take care of the mild and moderate symptoms. So we are not where we should be in taking care of the people who need care, and that's where we must implement some circuit breaker, reduce the numbers, continue to build capacity, and then reopen the economy slowly. It's going to be waves and cycles of that kind of intervention for some time.
Looking at COVID-19 and this new buzzword globally, circuit breaker. So just take us through the circuit breaker terminology and how it's then being applied globally, Dr. Githinji.
Well, the circuit breaker is really just terminology. It's obviously just a buzzword, but it started off much earlier in Singapore, about April. That's when we saw the first use of this terminology, but it's now been used again largely in the UK. The reference of the circuit breaker is an analogy similar to electricity, where if you have a surge in electricity, instead of allowing it to destroy your fridge, your microwave, and your other equipment, there's a circuit breaker that's put on in your system so that if the surge comes, it shuts off the electricity and protects the equipment. So it's just an analogy to say, if we are having COVID, I say the most important thing on COVID is to look at the force of transmission and the percentage of people requiring hospitalization or hospital care. So if you see that and maybe I go back to say that when you talk about flattening the curve, this is exactly what we're talking about. So even when you talk about circuit breaker, a circuit breaker is a flattening the curve strategy. It is saying we are seeing the curve is rising. We are seeing that by rising, maybe our level of the health system is going to be surpassed and overwhelmed. So let us circuit break so that we flatten the curve and make sure that we don't go above our health system as we wait to probably reinvest in it or just reduce the numbers over time. And you could actually do that multiple times. If you are not able to raise your health system capacity fast enough, you could use circuit breaker measures over time to reduce the force of transmission and to interrupt the force of transmission. And you don't have to do it once. You could do it again and again and again. So you could say, right now we are seeing 600, 1,000 cases a day. We want to make sure these come down to 200 or 300 because we think we can handle those. So you put a circuit breaker. When the cases come down, you then reopen. And when they rise again, you put another circuit breaker. So it can be multiple interventions. But it's really saying stop the force of transmission to stop overwhelming the health system. And you could actually do it over and over again.
What are the parameters? What is it that you use to tell that you've reached a level where you can switch back on the power?
So the issue here is that even before you start the circuit breaker, you're looking at why are you doing it. The first reason I said earlier, you're doing it because you're probably having too many people needing hospitalization or needing hospital care, too many people needing ICU, too many people needing ventilators beyond the capacity you can afford at that particular time. And this is not a Kenya problem. We've seen globally that health systems have been overwhelmed and unable to manage cases. So it's not, we need to tell our listeners and viewers, it's not a Kenya problem. It is actually a pandemic issue. So the parameters are, if you know that you have so far probably 200 beds of ICU, or you want to make sure that you have minimum numbers of people hospitalized, then you know from projections that actually you know that if you have 1,000 cases, that's why all the data we have should be used to kind of make these projections. That when you have 1,000 cases or you have this rate of positivity, this is the number of people expected to go to hospital for hospitalization, and there are new counties also coming, so you also have to account for the ones that are coming that you have not already had. Then when you do the circuit breaker, you say we are going to reduce our positivity rate down maybe up to 5%. When you approach that 5%, you could then open up, and when the positivity rate starts rising again towards 10 and above 10, then you could do another circuit breaker. So you could use multiple parameters, number of people in hospital, and also positivity rate. But then you also have to couple these up with a very robust strategy of contact tracing, surveillance, and testing. They have to be coupled together, and also data and data analysis. Yes. You can't do it blindly.
Thank you. If we look at where we stand right now as a country, in areas that are easy to define and probably determine, like the data that we have and which we trust will inform us on the way forward, would you say that we are competing favorably with the virus? Are we in a position to actually provide a clear and positive way forward to our citizenry?
Well, that's a difficult question, because I don't think anyone can answer that question succinctly as you've asked it. The issue is that, as I said earlier, in a pandemic, fear is part of it, panic is part of it, and the virus is always ahead of you. So when you think you managed it, when we saw the wave or the curve of Nairobi and Mombasa coming down, we thought the national curve was coming down. And it wasn't. What was happening was that the coronavirus came first to the urbanized towns, that was Nairobi, Mombasa, and as they were going through their first peak to come down, the other counties, Western Gishu, Eldoret, the other semi-urbanized or second-generation urbanized cities, Kisumu, Eldoret, Nakuru, were also starting their peak. So it's always ahead of you. And right now, I cannot tell you that we know exactly which the next set of counties to have acceleration is going to be. But what we need to do is that we need to increase what we call precision public health. That when you see a positive case, you can trace it back to where it came from. We know that most of the cases come from household clusters. They're households, and they're community clusters. They're a church. There is this and that. So this data is needed at a very granular level, at a sub-county level. What I know now is that most of our data and our surveillance capacity has remained at the national and county level. The government needs to work to devolve this capacity to the sub-county, so the data is very granular. Then I can be able to answer that question. Right now, I do not think we have enough data at some county level, that we are collecting enough. We have demotivated staff in many of the sub-counties because they're not being supported to go out and trace and survey and trace. We have fears of PPEs. We have fears of people getting infected. And therefore, the tracing and surveillance activities at sub-county level are suboptimal. And therefore, we are lacking a big chunk of the controlling the virus at that level.
Dr. Mercy, given that you are a media person, do you think, if I were to refer to the variable of fear that Dr. Githinji has mentioned, what part have we played, from your perspective, in alleviating these fears or in bringing them to a rational perspective where they're easy to understand and to function with?
Okay, that sounds like a difficult question to answer. Because, I think we have all been learning along the way as we reported COVID, as the government tried to contain COVID, as the public was coming to terms with COVID. So I think it's been, we've all been learning and evolving and moving along. And I wouldn't point fingers to anyone really, but I think everyone has played a role in either alleviating fear or fueling the fear and the stigma around COVID-19, probably in the way that we are reporting the COVID stories. When you listen to the Ministry of Health and say, you will die, that puts a little some fear in people. Then along the way, people stopped fearing and they stopped caring. As recent as this weekend, there are people who still don't believe that it's COVID. So I think it's a mixed variety of feelings for everyone around. And we've all played a part in it. Maybe as media being the channel in which we take that information from the ministry and give it to Mwananchi, then Mwananchi is in fear or stigma. But the thing that I've seen, and for me what is encouraging, is that the healthcare workers, the healthcare personnel are confident now. There is a bit of anxiety about them contracting the fear, but when it comes to managing people with COVID-19, I think I've seen a level of confidence that was not there initially. So I'm hoping that these people will be the change ambassadors, the people who would deliver the message now at the lower levels, as Dr. Githinji puts it, at the granular level, so that people can be able to understand from those peripheral counties that initially had not been affected by the COVID-19 pandemic, that they would understand what it is all about and how to protect themselves, so that now we start having a little bit more community engagement, as opposed to here before it was a top-down kind of management of COVID-19. And I think that has been what has been the problem, because people down here have just been bombarded by information, but there's no channel of community feeding back to...
Mercy, let me ask a simple question. How many stories of hope have you seen in this COVID time that has been out in the media? Because I'm sure there must be stories of hope. How often do we bring them out and say, these are the positive things that we see coming out of this, despite the really dreary and dark picture that we constantly put out about COVID?
And hope about the disease itself, not about the economic situation.
No, just the disease, not the economic situation.
So got it recovered, and this is what they went through.
Yes, meaning sharing testimonies, saying things that would lift people's hearts, because this narrative of people don't believe, I actually don't believe it, but that's another discussion. I don't believe that they don't believe there's COVID. I believe they'd rather not believe there's COVID.
Or they choose not to believe that
yes, there's COVID. It's too much of a burden to accept that there's COVID.
Mm-hmm. You've really put me on the spot. The two of
Mercy, that was not my intention. I was actually hoping to benefit from your vast knowledge on this subject, and and hoping that our listeners and viewers will also share in that vast knowledge that you have on this particular subject.
No. I think I would agree that we've had very little or very few. Like when you asked, and I was trying to just think of the stories that we've had about COVID-19, there have been very few stories about hope. I think for me, the only stories on hope that we have had out there is maybe on the innovations around COVID-19, where we're seeing people trying to do things differently to aid in hand washing. People are trying to make ventilators, locally manufactured ventilators, But in terms of the disease itself, I've actually must confess that we have very few stories, if any. Let me not say none, because none comes to mind. But I think we've had very few stories about COVID-19 and the triumphs that have come from there. I think we have been focusing on, the challenges and the hardships that people are going through, which is fair, because we've seen families that have struggled with COVID-19. We've seen some of the things that have been done that haven't been right, that we have highlighted, and things have had to change. So I think there's space for all of these things, but maybe we need to do a little bit more on stories of hope, but still not forgetting that there are also those people who are facing challenges. And when you are the one facing that challenge, it is 100%. It may not be as much as everyone else, but when you are going through it, it is 100% for you. So I think we need to just strike a balance.
See how to balance it. And actually, it's true. If you even look at even the negative stories about COVID-19, they're not around the disease itself.
No.
They're around everything else. They're around the scandal, the KEMSAs, everything else. But the story of this person went into ICU, or their condition deteriorated and they went into ICU. Even those have not been told. But also, and I remember somebody once told me that one of the strategies that also the Ministry of Health should deploy in communicating the issues of COVID-19 is tell the actual stories of COVID. Not everything else around, but tell the actual stories of COVID. You've seen somebody who has gone through it, has recovered. Tell the stories. Tell the stories of those that are taking care of people in home-based care, or tell the stories of the people who are in home-based care. And the government can also be at the forefront in championing such a cause. What do you think, Dr. Githinji?
Well, I think the positive story of COVID is in the numbers. The first thing I would like to say is that the reason people don't believe there is COVID or say they don't believe, because I hear what you're saying, is because of it's not because of COVID itself. It's because of lack of trust in their own government. It has nothing to do with COVID. It has very little to do with it. Most of it has everything to do with lack of trust in the government, and this lack of trust is not COVID-related lack of trust. It is lack of trust over years of government making promises that doesn't meet, and also people feeling disillusioned about jobs, about this and that, and then the scandals, and over time people have lost trust in government. So when something like this comes, you had very early people saying the government is doing this so that they get aid from World Bank. They know they're doing this so that they can steal money on PPEs and this kind of thing. That reflects not COVID. It reflects lack of trust. So the first lesson is that the government must embark on a process of earning trust from its citizens, not on COVID generally. And that means getting down to the communities and earning their trust. Now, if we want, as a media, to build the story, a hope story on COVID, then we have to look at the numbers. That 9 out of 10 people who actually get COVID have absolutely no symptoms. I think the challenge you've had is where we are telling people that if you get COVID, you'll die. And I think Mercy is trying to allude to that you'll die, this is going to kill you. Then people are looking around them and saying, I'm not seeing anyone dying next to me, but the people next to you have COVID. But you see, we've sold it as if it's a death sentence. So we must go back and say, guys, out of 10 people who get COVID, 9 may not even know it unless they are tested for purposes of public health measures. Only one person may have any symptoms of cough, fever, or difficulty in breathing. And even out of that one, only 0.something% will go to hospital. So generally, we are telling you about COVID so that you protect those who may need to go to hospital. And this is what happens when they go to hospital. But remember, getting COVID is not a death sentence. You will die. You may not even have symptoms. We have to tell people that you have to tell people this number. A lot of the people think that when you get COVID, in fact, that's why parents now are afraid of taking their children to school, because they think my child will get COVID, and when they get COVID, they die. Yet we know that children will get COVID, but they have an innate immunity that protects them. And the fatality rate in children is extremely low. They have only been 3% of our total fatality so far, So we have to sell this story of hope that COVID is a virus, it comes through you. In some people, it will complicate. In majority of people, it will not. That's the story we need to explain to the people.
Bringing the conversation back to the circuit breaker and then the steps that need to be taken because we have a surge in numbers and the circuit breaker. Do I hear you, Dr. Githinji and Dr. Mercy, saying that then the advice that you would give the government, if you are called in, and I'm sure, Dr. Githinji, you're part of the Brain Trust, if you are called in by the president on Wednesday and you asked, what should we do? Among the things you'd say is, let's break the circuit, and therefore you're telling us that we should have X number of days of lockdown, cessation of movement?
No, for me, it's not as general as that. My advice would be, they're what we call high-risk sectors. So transmission happens in particular scenarios. So you look at it, you say, fine, we are getting a lot of transmissions, what I like to call it the force of transmission. The force of transmission is high. Therefore, you're getting one person infecting many people, and that's why we are seeing so many, kind of this geometric growth of numbers. So you ask yourself, what are those factors that you can actually interrupt to ensure that you reduce the force of transmission? One, you must reduce crowding. I like to call it the 3 C's. You must reduce crowding. You must reduce close contact. And you must reduce closed spaces. And on those 3, I like to add T. You must reduce time spent in any of these 3 C's. Time spent in crowding, time spent in contact, time spent in closed spaces. So if you look at those 3 C's and T's, then you look at different sectors and you map them. It will be very clear which sectors you need to take a step back on. Because there are the sectors where people are actually spending more time in closed spaces, more time crowding, more time contact. So you may say, for example, that we are going to take back social gatherings and say we are actually reducing social gatherings for a month. We are saying we are probably going to ask the bars to have a shorter time and maybe bring back the curfew to 9 p.m. and so that you say then you reduce the amount of time that people are in those closed spaces. You may also want to say that actually if the infection continues, you may want to say no alcohol in those social places. But that could be also for 30 days, and then after that, you circuit break, the curve starts to bend, and then you reopen them again. So you must look at those 3 C's and the T, and then look at the sectors that have the highest risk on that framework, and those are the ones you take back on. It's not a general lockdown for 2 weeks or lockdown for a month. You need to look at the high-risk sectors.
And Dr. Masi, as that happens, then what should the government be doing?
I would want to add to that in that, one, you're looking at the transmission, but also you have to look at the point where you make the diagnosis, you do your surveillance, and you offer care to people who may need that care. And for me, I would look at focusing resources to our facilities. And when you talk about facilities, it's not just, your referral facilities, your level 5 facilities, but devolving all this to even the smaller units at the sub-county level, where people are able to, one, diagnose people who are likely to have COVID-19. Two, they're able to do contact tracing at the sub-county level so that they're able to quarantine and contain at the household levels or at the community levels those people who have been exposed to the virus. And three, they are able to isolate, even at the sub-county level, even at that small facility, they are able to isolate anyone who has had COVID, and they are able to monitor people who are in isolation at home so that the kind of people who have been infected and who need care, where they need care, whether it's in hospital or it's at home, so that you do these two things concurrently. One, you're stopping super transmission, and two, you're also taking care of those people who have already been exposed by making sure that, one, they're in quarantine and others are in isolation. And then now the last thing is to make sure that the places where critical care is available, and I say this because of the challenges we've had, Dr. Githinji has aptly said that we have about 400 ICU beds. You make sure that the places with this capacity, and the capacity is not just the beds, because you're looking at all the equipment that comes with critical care. You're looking at the personnel, and personnel is not just doctors, but also nurses in critical care. You're looking at people who can do dialysis, both nurses and doctors, because all of these things go in hand in hand. You're looking at laboratory capacity to handle ICU care. You make sure that you have adequate isolation for people who will need COVID-19 critical care, and those that will need other critical care needs not because of COVID-19, so that you're able to handle that at that point so that you don't have people dying. Because we've seen that people have come out of ICU even after having COVID-19. So it should not be that because you've had COVID, then you will definitely die. We should be able to offer that critical care.
Thank you very much.
Last thing that I would like to say just briefly is that our hospitals also need to be able to triage people who need, because we've seen that other healthcare services have been affected. So our hospitals should be able to triage and be able to test before they admit people, before they take people to surgery, so that they know who has COVID-19 or who doesn't, so that they can appropriately make the right decision, so that they continue offering care to other people. Because when people hear our hospitals are overwhelmed, then they think if I have a stroke, for example, then there's no space.
Then there's no space for me in the hospital.
Able to make sure that other healthcare services continue being offered, even as we do COVID-19 healthcare services.
Dr. Masi Korir, Group Editor in charge of Health and Sciences at the Standard Group, and Dr. Githinji, Group CEO at Amref Health Africa. Thank you very much for speaking to us this morning. And we'd like to just request that you allow us to get back in touch with you after this meeting on Wednesday, but between the President and the Council of Governors, to see the measures that they come up with, and also now to review and see what kind of effect should we expect to see out of that. Asante sana, and we wish you a good day, Dr. Githinji and Dr. Masi.
Thank you very much.